Jagdish, Dr. Sarachandra, for having me along with you on this wonderful Sunday morning. Lovely weather in Chennai, and I hope all of you are having a very good Sunday. Without wasting my time, the topic for me for today is optimal medical treatment of chronic coronary syndromes. Now, this term chronic coronary syndromes itself is actually coined last year by the European Society of Cardiology, and they brought up this term in place of the usual term, what we call as the stable coronary artery disease. So in place of that, they brought in chronic coronary syndromes and gave 6 clinical scenarios which are included in this. One is the suspected coronary artery disease, which is stable angina, new onset heart failure or LV dysfunction with suspected coronary artery disease, patients who had a revasc or an ACS less than 1 year following the event, and more than 1 year comes into the 4th category. The 5th category is separately vasospastic or microvascular disease. And the 5th category is CAD that is detected on screening. You do a master health checkup and find out those are the persons with CAD and at screening. Now, what I shall be doing is giving you an approach which the Europeans came up with and adding up a few things to those same methods. The first step in the approach to a chronic coronary syndrome when you start trying to treat them medically is assess the symptoms and perform clinical investigations of unstable angina. So first, if the patient has got unstable angina, they don't fit into us, they're straight away going to be treated according to the ACS guidelines. The second one is look at the comorbidities. Now that is important because if your patient has got a general condition that's not fit for revascularization, don't waste much time. Don't try to do too much of clinical testing. Minimize your testing, and you can even do a trial of anti-anginal drugs even if you're diagnosed unsure. So this is an option that is given in step 2. The third step is when you start investigating these patients with the ECG routine, metabolic profile, the X-ray, and the echocardiography. And if your echocardiography shows an ejection fraction less than 50%, they fall into the category of new onset probably ischemic cardiomyopathy or ischemic LV dysfunction. Now, this is a slide from May 2020 by Basai et al. And this is a very interesting slide. I put it up because they call these the 4 pillars of chronic heart failure therapy, which comes as chronic coronary syndrome, because these are going to be the 4 pillars. If you put a patient on ARNI, the beta blocker, the MRA like the spironolactone, and the SGLT2 inhibitors, your absolute risk reduction for mortality is going to be 25% and 72% relative risk reduction. So the number needed to treat over 24 months is something like 3.9, phenomenal. So remember, in your chronic coronary syndrome with heart failure, put them on all 4 drugs. It's absolutely essential. The next step is the patients who come up with some kind of chest pain and you want to assess those patients. Now, how are you going to track these patients? Now, the first thing you do in any chest pain is look at the pre-test probability. There have been several pre-test probability scores like the Forrester scores that have been going on. But now what happens is you look at the pre-test probability. They felt that only 3 factors are important. One is the nature of chest pain. It could be a typical angina, chest discomfort, or an equivalent that has an exertional component relieved with rest or nitrate. The typical, if you have 2, it becomes atypical and non-anginal if you don't have any of these features, or even dyspnea. So what they felt is the nature of the complaint, the age, and the sex are the 3 important factors to look at the pre-test probability. Now, this can be compounded or added with other possibilities that increase the likelihood of coronary artery disease. If you look at the conventional other risk factors like the dyslipidemia, hypertension, diabetes, smoking, family history, resting ECG changes, LV dysfunction suggests your coronary artery disease, abnormal stress ECG, and coronary artery calcium score is coming up in a big way because if your coronary artery calcium score is 0, there is a less than 5% annual risk of an obstructive coronary artery disease and a less than 1% annual risk of mortality or a non-fatal myocardial infarction. So based on this, you look at what is the likelihood your patient is going to have. If the likelihood is less, what you do is you probably do a CT coronary angiogram. And if the clinical likelihood is very high, don't waste time, probably go for a straight away do an invasive coronary angiogram, probably supplemented by the FFR or the IFR that needs to be done. So if you look at the entire scenario, based on the pre-test probability, low risk or the low probability are going to get a probable CT angiogram, and the high risk with more than 90% stenosis straight away go for an intervention. And if you're not, then what happens is you look at their other assessment factors and then treat them. But in between is the category where you have a case for the non-invasive testing and probably drug trial also. Now, which are the patients who are going to be high event risk patients? These are also defined by the Duke Treadmill score, the SPEC stress echocardiography profile. I think all of us know about this. And if you're still not sure in an angiogram, there is a big stress on the FFR or the IFR that is also being clinically used nowadays. The first step in medical management, all of us know this very, very clearly. I want to just put it for complaint that you have to go for a smoking cessation, diet, and the lifestyle modification. This is absolutely essential as part of the management. Next come the drugs. When it comes to management of chronic stable angina or the chronic coronary syndrome with angina, there are two categories of drugs that are available in clinical practice. One, those that provide symptomatic relief, and two, those that prevent cardiovascular events and mortality. Now, these are the drugs that improve survival and prevent events. Those are only three drugs: aspirin, statins, and ACE inhibitors. Now, the beta blockers improve the survival or the mortality reduction only in the presence of heart failure. Otherwise, what you know is the other category of drugs. Now, what I want to do is spend 1 minute on this particular aspect of statins. Now, the most neglected portion is the statin therapy or the cholesterol management in the chronic coronary syndromes. Now, this is the Lipid Association of India guideline, and this clearly shows anybody with an atherosclerotic cardiovascular disease or even a diabetic with two risk factors. What are the risk factors? Simple risk factors: age more than 45 or 55 for a female, family history of coronary artery disease, smoking, hypertension, low HDL. If you have two of these risk factors, your target LDL is going to be 50 milligrams. How many of us reach 50 milligrams? You try to achieve 50 milligrams, which is absolutely essential in these group of patients. Once you've tried to achieve this, next step is going to be to see what are going to be the anti-anginal drugs. As ACE inhibitors, everybody should be getting. I will not go too much into that. There are two lines of treatment which we are conventionally used to. The first line agents are the nitrates, the beta blockers, and the calcium channel blockers. The second line is going to be nicorandil, ivabradine, ranolazine, and trimetazidine. Now, the European guideline has come up very clearly and said the first line is going to be more of a beta blocker, and if you can't tolerate it, possibly the calcium channel blocker, and then the other four drugs in the second line. Now, this concept is slightly varied now because you can't channelize it for every patient. You will have to be looking at standard therapy depending on the other additional factors like the heart rate, blood pressure, and the LV dysfunction. Now, this has been beautifully exemplified by one particular article called the Diamond Approach for the Treatment of Chronic Stable Angina by Roberto Ferrari et al., wherein he said, look at the heart rate more than 70, less than 70, presence or absence of blood pressure, hypertension or not, LV dysfunction, heart failure, and atrial fibrillation. Now, this is horses for courses approach. Now, if you have a higher heart rate, obviously you give a beta blocker. If they don't use a verapamil or a diltiazem and ivabradine. You try to avoid the nicorandil, nitrates, and dihydropyridines, which are going to affect the heart rate. That is going to increase the heart rate. So, based on this, you come to a conclusion. Like, for instance, if you have hypotension, you use trimetazidine, ranolazine, ivabradine, which are neutral to the blood pressure. So you look at these factors and don't go for the conventional beta blocker, calcium channel blocker approach. Depending on the blood pressure, heart rate, and the dysfunction and the atrial fibrillation, you go for these drugs. The second one is also you look at comorbidities. Like, for instance, if you have a person with chronic obstructive airway disease, you don't use a beta blocker. And even if you're going to use one, use a very selective beta blocker. Or if you have a microvascular angina, probably the nitrates are going to work. The nicorandil is going to work. Calcium channel blocker is going to work. So depending on your hearts that you're going to be working on the course, you select your agent and don't go for the conventional management, is the conventional management. And you can combine any of these drugs, but remember, don't try to combine beta blockers with too much of diltiazem and verapamil. And diltiazem and verapamil with ivabradine is known to produce sinus pauses. You have to be a little cautious trying to avoid this also. Be careful with that. The second aspect is the antiplatelet therapy in chronic coronary syndrome, which has evoked a lot of interest in the last 1 year. Clopidogrel, 75 milligram, prasugrel, rivaroxaban, and ticagrelor. What is new is the rivaroxaban. The rivaroxaban being used in these group of patients has come into this in a big way, because what we are looking at now is what is called as a dual pathway inhibition, not just the antiplatelet therapy, but also looking at the antithrombotic therapy, thrombin inhibition with a low dose rivaroxaban of 2.5 milligram twice a day. Now, this is going to be very effective. When this is compared with the other dual antiplatelet therapies, you will see that compared to the clopidogrel in Capri trial, which had a 9% reduction in MACE, rivaroxaban 2.5 twice a day showed a 24% reduction in MACE. But what are we worried about? What we are going to be worried about is we are going to be worried about the amount of bleeds. Now, if you look at the bleeds, the major bleeds are much higher when you use ticagrelor, like in the Pegasus trials, 90 or the 60. Even in the clopidogrel, 60% bleed, but look at the 2.5 rivaroxaban, the major ISTH bleeds were only 70%, meaning that there is a case for it. So when is this case supposed to be useful? When are you going to start using this drug? This drug is going to be useful in high risk of ischemic events patients where they are going to have diffuse multivessel coronary artery disease with any of the following: either diabetes, recurrent MI, peripheral arterial disease, or a chronic kidney disease. Or if you have a moderate risk, you can consider where you have any one of these factors that is going to be sufficient. You can start using these drugs. Now, the microvascular angina is given a specific importance, and that is classified into two categories: microvascular angina into those with impaired microcirculatory conductance, where what you look at is the CFR. If the CFR is less than 2, you can treat these patients with just beta blocker, ACE inhibitors, and statins. The arteriolar dysregulation, where the acetylcholine test is positive, is treated like vasospastic angina. And how are we going to treat these vasospastic angina? Calcium channel blockers and long-acting nitrates. Now, interestingly, nifedipine has been found to be very effective in vasospasm following stent implantation for completion. But there are a lot of experimental modalities which come into the picture. We keep talking about these: the external counterpulsation, coronary sinus constriction, the spinal cord stimulation. All these are class 2B indication are really not indicated, and the TMR has now gone into a class 3 indication. It's not as rosy as life looks like. Whenever everything goes clearly, like Swami Vivekananda said, in a day when you don't come across any problems, you can be sure that you're traveling in the wrong path. So medical management is not going to be the only solution. There are a lot of problems, and we look at a few problems in the next 2-3 minutes. The first problem is what came up with the ischemia trial. I'm sure Dr. Charit Chandra is going to object to whatever I'm going to say in this. The ischemia trial tried to compare optimal medical management with invasive management, either with a CABG or a PCI. They looked at CT coronary angiogram, removed those with left main coronary artery disease, and also eliminated patients with a significant LV dysfunction, ACS within the last 2 months, and PCI or CABG within the last 1 year, EGFR less than 30, and very symptomatic patients that are not responding to medical therapy, and then split them into 2 categories of invasive and a medical management, optimal medical management, very strict medical management. Now, what happened was, within the first 6 months, you look at this, the red line is the PCI or the invasive management to PCABG also. Within the first 6 months, the conservative management was superior by about 2% absolute risk reduction. But when it came to 4 years, the trend reversed, and 2% had an absolute risk reduction in favor of invasive management. The final summary was that most of these patients have a benefit within 6 months for a conservative arm, but at 4 years, there seems to be a benefit with the invasive arm. Peri-procedural MIs were increased in the invasive strategy, but spontaneous MIs were reduced in the long-term management of the invasive strategy. There was a low overall all-cause mortality, indicating that the medical management has improved a lot, and very low rates of procedure-related stroke and death were also found out in these patients. There's a lot of argument on this, but I just wanted to put it across in a chronic coronary syndrome. The second interesting point is what most of us do once your patient comes back after about 6 months or 1 year. Once the cholesterol levels are very low, we tend to reduce the high-intensity statin. Now, this is a very interesting study which shows that if you reduce the high-intensity statin to a non-high-intensity statin, even within the goal, the goal was just about 70 milligrams of LDL cholesterol. They found if you're not on a high-intensity statin, the incidence of MACE comes up. Even if in the propensity match population, the MACE goes up. So please continue high-intensity statins and do not stop the high-intensity statins at any point of time. That's very, very important. The new point about the heart failure is that there is a new category of patients who are improving, and these are called heart failure with improved ejection fraction. And once a recovered ejection fraction, there is a new criteria. One thing, remember, don't stop the drugs. If you stop, 40% are going to recur. Guideline clearly has come up this year in the current issue of JACC, which says for every 6 months, repeat an echocardiography for about 1.5 years, and then every 1 to 3 years, because there is a very strong likelihood of recurrence of these particular patients. So finally, to summarize what I have said, there are 4 pillars in the management or vascular protection for chronic coronary syndromes: lipid lowering, BP control, glucose control, and antithrombotic protection. Now, there is a change in each one of these. We have seen the antithrombotic protection. The lipid lowering has also undergone a change because we are still looking at LDL cholesterol. The concept is changing because the apolipoprotein B is going to be the more important thing. Conventional wisdom has told us small dells NDL is more important. The large buoyant LDL is not important. Look at this cartoon. Just one small point I want to make. The small dense LDL, if it is there, tends to get accumulated within the cell and produces an unstable plaque. But the large LDL, which contains more of cholesterol, now what we are looking at is we are not looking at cholesterol as the amount. We are looking at the large cholesterol particles. They deposit more cholesterol within the cell and increase the size of the plaque. So both are dangerous. So you look at the cholesterol value, it's not going to help you much. So look at apolipoprotein B, because now all the particles are equally bad and raised, and you have to reduce the entire apolipoprotein B, which is going to be the future target for management of chronic coronary syndromes. HDLC has lost its importance because HDLC just looks at cholesterol value. It does not tell you anything about the functionality of HDL. So HDL is no longer considered as important. In terms of hypertension management, only one point: don't bring your blood pressure below 120/70. Otherwise, in this category, I think the beta blocker and ACE inhibitor is going to be important. Diabetes has undergone only one change. Even in metformin naive patients, you can stall these patients on SGLT2 inhibitors, which have been proven to have benefits in our entire group of ASCVD patients. And not only that, the high and the very high risk severe risk patients are also benefiting. So probably you'll have to start treating them with SGLT2 inhibitors even without metformin. So these are the 4 pillars. So after these 4 pillars, are there any scope for improvement? What we are going to see in future is this. We are looking at an LDL less than 50. If you're not going to reach it, go for an ezetimibe or the PCSK9. HSCRP inflammatory concept has come in. The Cantos already came up with canakinumab. The Colcott is also coming. The Lodoco is coming up in the ESC shortly. Dual antiplatelet therapy with the COMPASS trial and the DAPT trials have said there is a case for that also. Whenever the triglyceride is a risk factor, the REDUCE-IT trial showed clearly that icosapentaethyl at 2 grams twice a day is useful. And finally, the LP-little a is an independent risk factor for India. And you must remember that the newer concept is that it is an independent, unpredictable factor, but the PCSK9 reduction of LPA has been found to be useful. I don't have time to dwell on all this. With this, I think I will say thank you to the organizers and to the chairperson and my colleagues. And I will let you dwell on it. We'll take the questions. I'm sure there are going to be questions. I've raked in a lot of thoughts for thinking. And I think I should give it back to Dr. Amit for further discussion. Thank you, Dr. Amit.
Thank you very